I'm Alan Weil, Editor-in-Chief of Health Affairs. Thank you for joining us for this event, Health Reform from the Midterms to 2020. We're very pleased today to be releasing ahead of print 2 papers. They're available on our website, and they'll be included in the December print journal for those of you who still look at health affairs on paper. The 2 papers are how Democratic candidates for the presidency in 2020 could choose among public health insurance plans, and Getting Ready for Health Reform 2020, Republicans' Options for Improving Upon the State Innovation Approach. We're grateful to the Commonwealth Fund for supporting the event and the work that led to the creation of these papers. And I'll just spend a moment saying that it is often said, of course, at the moment the midterms end, it's time to start focusing on the presidential election. And that's true, but I think when people say that, they're often referring to the politics. We, of course, don't know who the Democratic nominee will be. We have a presumptive Republican nominee at this point. But the role we like to play at Health Affairs, and what makes this a particularly exciting collection of papers for us to publish and an event for us to host, is to start focusing on the substance, not the politics. There are key design decisions that will need to be made by the presidential candidates of both parties prior to when the election is held, and they're thinking about those issues now. And so it's terrific to provide an evidence-based and an analytically based platform for those discussions to occur before some of the political rhetoric ramps up, and frankly, before candidates lock themselves into positions rhetorically that they can't back themselves out of. It's nice to actually do the thinking so that they have a sense of the implications of their words. So with that very brief introduction, let me just give you a quick review of the day. David Blumenthal, President of the Commonwealth Fund, will give a few remarks, and followed by Jeanne Lambrew, Senior Fellow at the Century Foundation. We were hoping to have Erika Fowler speak to us about the role health reform played in the 2018 election. 7 inches of snow in Connecticut has interfered with those plans, and so we're going to have a little bit of a discussion unfortunately, we can't hear directly from her, but we'll have a little discussion, I think, that will cover some of the same ground. But then we'll really move our focus into presentations by the authors of our 2 papers, give them enough time to present some of the content and analytic options that they considered in those papers. We have 4 people lined up to give some reactions, and then we have an hour allocated to discussion, some of which I will lead and some of it which we will hope you will prepare your own questions to engage in. So that's what we're looking at today. I'll begin by asking David Blumenthal, President of the Commonwealth Fund, formerly Samuel Thier Professor of Medicine at Harvard Medical School. Many in Washington got to know him also during his tenure as the National Coordinator for Health Information Technology. David, some introduction for you.
Thank you, Alan. It's great to be here. Thanks for holding this event, and thanks to all of you in the audience for being here, and to our terrific presenters and to Health Affairs for their sponsorship of this forum and the work that it represents. It may seem astonishing to be discussing the details of health policy in advance of the 2020 election cycle, since the midterms are not even cool yet. It's still unfolding before our very eyes. But actually, this is exactly the right time to lay the groundwork for an informed, responsible, and successful debate about outstanding health reform issues during the next presidential election. So let me explain why I believe that to be true. History teaches us that the time for developing presidential level health reform policy is actually far shorter than most of us imagine. The logic starts with the realization that for significant healthcare change, new or re-elected presidents have barely 6 months to make their mark. To put it differently, the health reform presidency in our country is really 6 months long. The reason is that healthcare, as we have seen now repeatedly over the last 8 years and counting, is as politically fraught as any policy issue a president can address. It can actually make or break a presidency. People may not vote on it, but it can make or break a presidency. To be successful, therefore, presidents with ambitions to change healthcare have to strike when their political capital is at its peak, which is to say, the day of their inaugural address. Delay is fatal. Lyndon Baines Johnson collected his domestic and legislative staff about a week after his 1964 landslide election to talk about the implementation of the Great Society program, including Medicare. And he said to them, every day I'm going to make an enemy, every day I'm going to lose votes, and urged them to get acting fast. This was after a genuine historic landslide. Bill Clinton shows the consequences of dithering with the catastrophe that was his health care plan. So what does this mean practically? Presidents who aspire to change health care in any major way have to have a plan, or at least a well-crafted strategy, when they leave the inaugural podium. That means, in turn, that they have to have fashioned that plan well in advance, presumably during the transition. And that means they have to enter the transition period with principles and directions laid out, and with some thinking on the details. So when candidates formulate their healthcare policies in preparation for the Iowa caucuses in 2020, they will already be well on their way to success or failure with regard to any healthcare ambitions they have on election. To be ready for Iowa means, in turn, that by this summer or fall, they have to be actively thinking about first steps. So that's the logic behind this discussion, and that's why the Commonwealth Fund is so delighted to be able to partner with Health Affairs and the Century Foundation in bringing together our distinguished guests to start the ball rolling on this incredibly important discussion for the American people. Thank you.
Great. Thank you, David, and thank you, Alan. Also, thanks to the Commonwealth Fund and Sarah Collins for your support for these papers, this event, and the broader project called Getting Ready for Health Reform 2020, run by the Century Foundation. I'd also like to thank Mark Zuckerman, president of the Century Foundation. Started 99 years ago, the Century Foundation is a progressive, nonpartisan think tank that seeks to foster opportunity, reduce inequality, and promote security at home and abroad. Our health policy work, in particular, aims to inject information and ideas into often heated debates. As we'll discuss momentarily, health policy may be high on the agenda of the 116th Congress, given the midterm results. People voted in part to protect and improve upon the protections in the Affordable Care Act for people with pre-existing conditions. But perhaps equally important, this midterm election signals that the candidates' visions for the health system will be of great interest in the run for the presidency in 2020. So as Alan said, as David said, it may feel early to discuss the start of the next campaign, but there is a rhythm in politics, like the changing of the tide. The president's first 100 days, his first year in office, is over now, with his party, along with his party's control of Congress. As President Trump's power has ebbed, a new flow of candidates, issues, and ideas has begun to rise. And those ideas forged on the campaign trail matter. As David said, the first 100 days matter, and one analysis found that from Presidents Nixon to Obama, roughly 2/3 of their campaign promises were kept. Campaign plans set presidential agendas. They are the yardstick by which presidents are held accountable, and they ultimately matter in terms of legislative outcomes. So we are now at that moment when the landscape is taking shape and the general approaches to health system reform are emerging, yet key design elements of proposals have yet to be determined. And as recent history suggests, those details matter. After the 2006 midterm, when Democrats gained control of Congress with a Republican president, preparatory work intensified on major health reform proposals. This included, for example, numerous hearings. Both senators and presidential candidates had health forums on health reform. There was a principle-based business labor coalition that included Walmart and SEIU, focusing on this issue, and the Congressional Budget Office produced 2 full volumes on ideas for the incoming Congress to prepare for what was ultimately the debate and passage of the Affordable Care Act. In contrast, after the 2014 midterm, which produced mirror opposite results, a Republican Congress and a Democratic president, little apparent policy development occurred. For instance, Republicans held no hearings on the ways to replace the Affordable Care Act. Instead, they sent President Obama a so-called repeal and delay bill with no clear replacement for the law in the confines of that proposal. No consensus among conservatives and experts was forged, and some suggest that this lack of readiness contributed to the failure of health reform in 2017. So this project aims to shine a spotlight on this critical developmental period of time. Through this project, last June, I wrote a report on the Commonwealth Fund website on why people should pay attention to campaign plans. We'll hear from Lanhee Chen and Glied today on how to pick among and improve upon the likely Republican and Democratic approaches. Meena Seshamani will discuss an issue brief that she and her colleague Adaeze Enekwechi wrote on injecting delivery system reform into both approaches, and additional issue briefs on structuring choices and federalism are forthcoming. So hopefully today is the beginning, not the end, of a discussion on how to pave the way for a rigorous debate grounded in clear visions, acknowledged trade-offs, and an understanding of health policy and politics. So with that, I'll turn it back over to Alan to talk about the midterms.
Thank you, Jeanne. As I noted, our speaker in this segment was unable to make it due to weather, and most of our focus is going to be forward-looking, but we did want to have a brief backward look to set the stage for that. I'm going to just ask a few questions. We'll get the topic out here in a slightly different way than we had planned, but I'm confident we can cover it. Jeanne, you maybe could just give us a few minutes of what we know from the polling data about the role that health played, and then I want to dive more into some of the substantive details.
Sure. So we know going into the election that health policy was on voters' minds. The Kaiser Family Foundation has a tracking poll that found on October 18th, 7 in 10 voters said that health care is very important, more than the 64% who named economy and the jobs. We saw this morning a new analysis of ad spending. There was $5.25 billion spent on ads in the midterms, and healthcare was the single most discussed issue in political ads. Of the more than 3 million election ads that ran on TV this cycle, at least 1.2 million mentioned healthcare, according to Bloomberg News analysis of the Cantor Media data. And we also have heard at the end of the end of the cycle, the Congressional Leadership Fund, which is a Republican super PAC affiliated with Paul Ryan, started talking about Democrats' support of radical single-payer socialist plans, ending Medicare as we know it, and kicking you off your health plan. So we certainly heard a lot about health reform in these ads. Interestingly, health industry spending was not as high as in previous cycles. The financial services industry was number 1, healthcare was number 5, but we saw the emergence of consumer-oriented groups, the Patients for Affordable Drugs, which is a non-pharma-funded group, really got into a number of campaigns, and we're proud of the fact, in their view, that 72% of the top Democratic challengers rejected pharma money in going into their campaigns. We had little lobbyists, we had Protect Our Care, we had healthcare voters out there trying to engage kind of the grassroots groups before the election. And last but not least, healthcare was actually on the ballot. In states like Nebraska, Utah, Idaho, and Montana, voters went to say whether or not they supported the Medicaid expansion. So that's the going into the midterms. Coming out of it, I think everybody knows the statistics. In the Senate, it is at this moment 51-47. In the House, Democrats picked up 36 seats with about half a dozen still outstanding. Exit polls are clear. 41% of people voting said that healthcare was their top issue. That's coming out of NBC, Washington Post, CNN. Nearly double immigration, which was the second highest, and the first time in more than a decade that healthcare was higher than the economy. I'll just say one more kind of word about what the exit polls reveal. which is who do you trust more, was a question that often gets asked. Voters by a 58 to 34% margin said that they support Democrats more than Republicans on who's most likely to protect people with health care for people with pre-existing conditions. And a Politico Morning Consult survey said generally on health care, 48% trust Democrats more than Republicans, who are supported 35% of the time. So in the words of Chuck Todd, midterm voters gave Democrats a mandate to protect the Affordable Care Act, and this indeed was a health care election.
Okay, with that terrific overview of where the campaign went, David, I want to sort of pivot to the conceit of this kind of conversation that we're having here, which is that the details matter. And yet when I go back and think about what we heard in the campaign, and Jeanne, you mentioned some of it, the details tend to get lost. So for example, Democrats, as I saw it, decided they'll run on protection of pre-existing conditions, and Republicans said, well, we protect pre-existing conditions too. And indeed, they have various legislative proposals that have elements that of sort of old-style guaranteed issue, even if it doesn't necessarily protect on the benefit structure or other elements. Similarly, Medicare got thrown in as a they'll destroy it talking point in the absence of any plan that would do that. So I guess my question is, how do we take the Commonwealth Fund's substantive goal and the importance of working through the substantive details when we know what happens in the campaign is those details are all ignored, or they seem to be ignored?
So that's a great question, and thank you, Jeanne, for that terrific summary of the midterms. I think the answer to your question is that the healthcare debate proceeds at multiple levels. There's the level that is directed at voters and that signals the values of the candidate and their aspirations. And then there's the level that goes on at, there's a level of conversation that goes on at the among experts and the people who are supporting the president-elect or the candidate to fashion the message, but not to supply verbally the details. So I think that presidential candidates are well advised to have detailed plans, but not necessarily to share them. And at least not to share them with the intent of changing votes or messaging to a large electorate. There will always be folks like people in this room who will pore over the details, and there will be newspaper stories among the elite media going through those details, and they may come up in a debate, but they will not change votes. What will change votes is the overall message about caring about health and caring about coverage, or caring about decentralization and states' rights and less government. So I think those are at least the two levels at which the debate proceeds.
Oh, I'd like to give the American public and the people who try to relentlessly put facts in front of them credit, because, when you look back on when the president, when Senator McConnell, when a lot of these candidates said, oh, I care about pre-existing conditions, I promise I'll protect them, there was a question about, is that accurate, right? And I do think that between the legislation that was voted on last year in the House that passed that would have undermined pre-existing conditions, the kind of effort to pass similar legislation in the Senate, that was a long time ago, and there was some view that maybe that would fade away from voters' memories. But as everybody remembers, last October, the president did an executive order that would undermine some of those protections for pre-existing conditions. In January, a bunch of Medicaid work requirement waivers were supported, approved, which some would argue would undermine people with pre-existing conditions. In February, 20 state attorneys general launched a lawsuit that would try to enjoin the entire Affordable Care Act. And in June, the Department of Justice said, well, we agree the individual mandates are unconstitutional, but we just want to enjoin the pre-existing condition protections. And even as late as the summer, when some of the candidates saying, oh, I do care about pre-existing conditions, here's my bill, that bill wouldn't fully restore the pre-existing condition protections in the Affordable Care Act, which patient groups pushed back on and in fact said, in short, for people with pre-existing conditions, the bill would provide access to coverage in name only. So I think that this midterm is a reminder to people that policy does have political consequences, that facts do matter, and all the work to make sure people understand what is and is not the position of particular individuals and candidates is important.
So please.
Just, Jeanne is absolutely right on the importance of pre-existing conditions as an issue. There are several hot-button issues, and pre-existing conditions is a new one on the field, but there have been previous hot-button issues, particularly Medicare, where the details do matter. And I think one of the characteristics of those issues is that they threaten something people already have. And the mistake about pre-existing conditions, if it was a mistake that people opposed to the Affordable Care Act made, was not understanding the level of risk aversion among people, including voters. So I think that it's hard to come up with hard and fast rules. Medicare defies many of the rules of how healthcare debates take shape. It's always a dangerous issue, and pre-existing conditions, I think, has joined the pantheon of holy guarantees that the American government has made to the American public. So that we now have guarantees of care for the elderly, for the disabled, for the poor, and we've just added the sick. I think that's the context in which I see that particular debate.
I want to probably only have time for one more question. These answers are so great. I'd like to keep going. But Jeanne, I'm glad you brought up the issue of trust. So 25 years ago, I worked for Colorado Governor Roy Romer, and I remember sitting in rooms when the Democratic governors were told that healthcare was the issue with the largest trust division between the two parties, and that was a time, of course, leading up to Clinton's efforts to health reform. So this trust gap is an intermediary between policy and how people vote, because when someone says they're going to destroy Medicare or protect pre-existing conditions, the question is, do you believe them? So here's my question. To what do we attribute the rise of healthcare as now back to the highest level of gaps between the parties in trust? David, you just mentioned you can't threaten taking away something people already have. Did we go through a valley around, if you like it, you can keep it, and that destroyed trust, but that is now reemerged? Why are we now at a place with such a large gap between the parties on the trust issue? It seems like that is a defining feature behind the outcome of the last election and will be very central to how the candidates position themselves in the next election.
Do you want to go first?
So I don't know the history of the polling data on that trust issue. I can tell you when I worked for several Democratic political candidates, and over the course of the 80s and 90s, and then in the 70s when I worked in the Congress, it was absolutely clear that health was a Democratic issue and was not a Republican issue. So trust in the Democrats, just as people tend to trust the Republicans on the economy, they tend to trust Democrats on health. And that has always been true. And so what I see this as is a return to the normal predisposition of Americans and American voters to see Democrats as the people who care about healthcare services, especially governmentally provided healthcare services.
And I might just look back a little bit, because I think we'll talk in a moment about the role of government, which I think is actually something that is a clear historical partisan difference, and that might be what's going on with healthcare, is do you trust government or not about healthcare? But looking back, I think it's important to also just recognize that, some of the incoming class of House members are people who didn't necessarily win on the issue of healthcare, but are healthcare champions. Lauren Underwood, who is a nurse who worked at Health and Human Services, is a trusted voice on healthcare, and she is going to be in the House this coming session. Donna Shalala at the other end of the age spectrum is clearly a notable health hero and champion. And I think there's something about that people trust people who have experience in healthcare. And historically, there have been more physicians who run as Republicans and Democrats. I think that's changing. I think that's an interesting phenomenon. And I also think, going back to what do people want, part of this election was about checks and balances. So when you think about the incoming Congress, there's the what they won't do, what they could do, and what they will do. What they won't do is they won't, at this point, pass legislation that's going to undermine pre-existing conditions, cut Medicaid, and cut Medicare. Those are, I think, big, important priorities for voters that I think are now guaranteed. They could do some sort of bipartisan legislation on prescription drug pricing. Senator McConnell said the day after the election that he wants to do something potentially to fix Obamacare. And there's a bunch of must-pass bills that are going to be coming up in the coming months, so there's an opportunity for the could-pass bills. And then there's what will happen. And what will happen is oversight are the tools that the House has that could potentially look into the regulations that are undermining pre-existing conditions, intervene potentially in the Texas lawsuit, have hearings and set the agenda, and those are guarantees of what are the tools that come with a majority. So I think when we think through the intermediary between here and the 2020 election, there are, I think, opportunities to prevent, possibly pass, and certainly act on a healthcare agenda.
Well, you all brilliantly filled in for our missing speaker. We could debrief on the past for the rest of the morning, but it's time to move forward. Please join me in thanking our openers. Great. Sherry, Lanhee, if you want to move up to the front, I will introduce the two of you. As noted, we've released their papers this morning on design issues in the 2020 campaign. We're going to hear from Sherry Glied, Dean of New York University's Robert F. Wagner Graduate School of Public Service, formerly the Assistant Secretary of Planning and Evaluation at HHS. She's also been a professor of health policy and chair of the Department of Health Policy at Columbia University's Mailman School of Public Health. Lanhee Chen is the David and Diane Steffi Research Fellow at the Hoover Institution, Director of Domestic Policy Studies and lecturer in the Public Policy Program at Stanford University. He's advised a number of major campaigns, including serving as policy director in the Romney-Ryan campaign presidential election of 2012. We've asked each of them to take enough time to really walk you through the design considerations that they went over in their papers, and so without further ado, I'll turn it over first to Sherry. Welcome.
Good morning, everybody. Thank you. Alan asked us to actually situate our papers in a bit of context, so I'm going to do that at the beginning. And I want to note that this paper is joint with Jeanne, but I have not actually cleared my remarks with Jeanne, so any mistakes that are made are entirely my own. So the topic of our paper is what might the Democratic healthcare strategy in 2020 look like, and how might it incorporate public plans? And to set the stage, we've just been through 4 elections in which the Democrats played defense on healthcare, but the repeal and replace effort has allowed the Democrats to move to a different posture, and in the last election to actually be on the offense with considerable success, which suggests that the Dems are likely to consider healthcare very high on their list of priorities in the 2020 presidential election, building on the benefits of the Affordable Care Act. But what form will that focus on healthcare take? I think it's useful to think about healthcare in the American political sphere as really following 2 different parallel streams of thinking. One is a focus on healthcare policy as repairing a set of very specific, defined problems. That's really the genesis of the Affordable Care Act. We have a whole bunch of problems in our healthcare system. What policies do we need to put in place to fix them? And the ACA, working in that model, did a terrific amount of good in addressing the problems that had been identified, right? The number of people with health insurance coverage, the percentage of the American public with health insurance coverage is at an all-time high. Access barriers have fallen. Medical debts have fallen. All of the things that had been flagged as problems have, in fact, improved. Cost growth slowed, even despite the expansion in access. At the same time, looking forward, problems certainly remain. In opinion polls, a couple of things stand out. First of all, high costs. premiums, especially for people who are unsubsidized in the marketplaces, high deductibles and high cost sharing, both in the marketplaces and in employer-sponsored coverage, out-of-network costs, something we had not really heard about before, kind of a new problem, access to providers, the concerns about narrow networks, continuing concerns around pre-existing conditions, and of course the 28 million people who remain uninsured, many of them in states who did not opt into the Medicaid expansion. So we might imagine healthcare policy moving forward to address this set of tangible, specific policy problems. But there is also another long-standing health policy tack in the US, one that aims to build a particular kind of health system, often called Medicare for All. And this is not a new phenomenon. I want to do a little brief historical digression here, although it is really scary to do this sitting opposite David Blumenthal. But let me start here anyway. This idea links back to Medicare in 1965. And so I went back to say, so okay, we passed Medicare, this great, wonderful experience in 1965. What happened in the 1966 midterms? Well, nobody ran on health care at all. The war in Vietnam, inflation, urban issues dominated the discussion. Because Medicare had passed with somewhat bipartisan support, it was a hard issue to target from a partisan standpoint. And the 1966 midterms, after the passage of Medicare, this great triumph, was a red wave. Republicans gained 47 seats in the House and netted 3 seats in the Senate. And though the Democrats maintained an overwhelming majority in both chambers, the Republicans gained 8 governorships and tons of state legislative seats. It did not go at all in the way that one might have expected after the passage of a program that, in retrospect, seems tremendously popular. And if we skip forward to 1968, and the Republican presidential platform never mentions the word Medicare at all. And in terms of coverage, there is vague language encouraging the broadening of private sector health plans to cover more things than hospital care. That is addressing a specific and tangible problem. And if you look to the Democrats, the only thing that's in there in health coverage in the 1968 presidential platform is we need prenatal care for mothers and postnatal care for babies up to 1 year old. Again, a very specific, very tangible kind of problem, not building really on Medicare in any very specific way at all. But by 1970, 1971, Ted Kennedy had introduced the Health Security Act, a single-payer universal health insurance plan. In 1972, Michigan Congressman Martha Griffiths introduced the bill into the House. And pretty much continually since then, legislation has been introduced in both chambers calling for a single-payer health care bill along the Medicare for All lines. The current version, the current House bill was introduced by Congressman Conyers back in 2003. And jumping forward, of course, we have this continuous line all the way to Senator Sanders in the 2016 primaries. So there have always been these 2 parallel tracks in health policy. One track focused on specific, not always, but specific tangible healthcare problems, and the other really in parallel, focusing on moving in this direction of a single payer plan or Medicare for All. I think that one of the things that is likely to happen in the 2020 campaign is that these 2 tracks, these 2 parallel tracks, are likely to converge. That is, Democratic candidates are going to be thinking about solving a set of specific problems while incorporating some version of something called a public plan. So trying to bring these 2 themes together. The meat of our paper is, how could you do that? What are the ways in which you could do it, and why might you choose among those ways? So we begin the paper by asking, well, what is a public plan anyway? Medicare is the prototype, but even traditional Medicare is in some ways a hybrid. It's financed through a mix of taxes and premiums and considerable cost sharing. It is managed by CMS, and so it adheres to the transparency standards that govern all federal regulatory activities, but it's managed on a day-to-day basis. The claims are processed by private for-profit contractors. It pays largely fee-for-service, but by no means exclusively. Medicare has often been the innovator in payment design. Enrollment in traditional Medicare is nearly automatic, but very few people have traditional Medicare only, and the rest are either in Medicare Advantage plans or hold some sort of supplemental coverage. So even Medicare, even traditional Medicare is a hybrid. And then there's MA, Medicare Advantage. Is that a public plan? The plan is very heavily regulated by CMS. It provides risk-adjusted capitated payments pegged to spending in the traditional program. The plans, in principle, determine payment rates, but they rely rather heavily on the traditional Medicare fee schedule, both for the methods by which they pay and the levels of payment. There's more flexibility above a baseline in terms of benefits, and they can do utilization review. Is that a public plan? And then, though I'm not going to go into the details, we talk about Medicaid and CHIP, which are tax finance programs operated entirely by private managed care companies, or nearly so. And then there's the Veterans Administration, which operates its own health system. So while publicness is often associated with Medicare, in reality, there is a very broad range of things that you could call a public plan operating in the US health system already, and that is not at all unusual by international standards. Most countries combine many different types of governance in their healthcare systems. So as we think about expanding the definition of public plans to incorporate all the existing varieties, we can think of 3 directions forward. First, prospective candidates might pick and choose public plan elements that would be applied within the private insurance sector. For example, regulation of cost sharing or of insurer rate increases, broadening the reach of public program fee schedules, say for out-of-network services or as ceiling prices. Doing this would gain some public plan benefits, like reducing out-of-pocket financial exposure, but it would not generate a new plan, and it would have little impact on the federal budget. A second strategy would be to offer people the choice of both private and public plans. For example, offering a public plan in the marketplaces, the so-called public option, offering Medicare buy-ins to those 55 to 64, or maybe to anyone. Could be a Medicaid buy-in proposal. So these all offer opportunities for expanded coverage with no requirement to participate. The budget implications of these programs could be relatively modest, or even some of them might actually save money on the federal budget, such as offering a public plan in the marketplaces. And third, we could move to an expansive single-payer or Medicare for all plan, consolidating all financing and administration. Everybody would have health insurance. Out-of-pocket costs would be low or nearly non-existent. We would dramatically reduce the role of profits. We would substantially cut administrative costs. We'd have monopsony control over provider payments. We could replace premiums and cost sharing with taxes, and that might lead to lower overall costs. But replacing premiums and cost sharing with taxes would also make costs that are currently largely invisible to voters, such as employer contributions to health insurance premiums and the tax expenditures that go around employer-sponsored insurance today, quite transparent. And it would also make healthcare very large and forbiddingly obvious in the federal budget. The single line item for this new public plan would cost at least half of all federal expenditures. So how should candidates choose? Well, that depends on what they want and how they want to define themselves. If your first priority is to reduce profits, eliminate fragmentation, improve transparency, make the system sensible, democratically responsive, reduce overall costs, all those good things, you want to go for a single-payer approach. But the benefits of this plan, its transparency and its coherence, are also its greatest weakness. It transforms invisible costs into highly visible federal taxes, and those federal taxes are distributed quite differently from the premiums they replace. It will require some 175 million people with private insurance, most of whom report that they are quite satisfied with their coverage, to change insurance. Jeanne and I are veterans of what happened when single-digit millions of people had their plans canceled in 2013, so we are understandably trepidatious, I think. A second option is to promise everybody an affordable health plan option, either a public plan, maybe as a buy-in. That's politically attractive, but the devil is in the implementation details. We've had experience doing it in the challenges of regulating the Medicare Advantage program, which is a much more structured program, from standardizing benefits, which is a political hot potato, to risk adjustment systems and upcoding and so on. So Medicare Advantage provides a roadmap of the problems we're likely to face, the challenges. These need regular legislative and regulatory adjustments, and that could be pretty hard to pull off. Third option would be just to focus on the places and the problems and the populations facing the biggest problems. So for example, offer a new public plan option only to specific groups or only in specific areas, such as those 55 and over, or in areas where there's limited private insurance or limited provider competition. It would be a fallback option, similar to what exists, although it's never been used in Medicare Part D. It's kind of hard to oppose it. If there is no competition, what's so terrible about having a public plan? But it may also look a little weak tea. Doesn't seem, that's an old Canadian expression, right? It's not enough for those who want to move forward boldly, and it's too much for those who oppose more public intervention generally. A fourth option is to follow the late Uwe Reinhardt's admonition and focus on prices. So use Medicare or some other administratively determined rates in some areas for some claims or for some services. That would bring you some public plan benefits without any financing or premium issues. But as with any public plan model, all of the above, you have to get the prices right. If the prices are too low, providers won't participate. But even above that, basic standard, administered prices are problematic, hard to manage. You can freeze payment methods into place, freezing into place fee-for-service insurance, for example. Although, in fact, Medicare has been fairly innovative. But you can also freeze, and this is much more of a challenge, payment levels into place. And I think recent research on the ROC, for example, suggests that when technologies change, it's really hard for Medicare to keep pace and to update their prices frequently enough. Transparency and lobbying can make price setting very kludgy in the U.S. context. And I think, actually, although I'd like somebody to explore this, the structure of the U.S. government makes this harder to do here than it might be in some other places. Final consideration, I think, for candidates is scale. Do you want to come out with something big and bold, or do you want to offer something smaller as proof of concept, signifying the intention to build on it over time? Of course, that brings us back to Medicare, which was seen by many people as the platform for broader expansion back in 1965 or 1970, and in 48 years never really did achieve that promise. So you can say that you're going to start small because you're going to build on it, but will you ever actually build? That is the landscape. A lot can change between now and 2020, just as a huge amount changed in the short time between the passage of Medicare and the elections of 1968. But given the cost and complexity of our healthcare system, it's going to take a long while to iron out the details of whatever plan someone proposes. And so this is the right time for candidates to start thinking through these questions. Thank you.
So unlike Sherry and Jeanne, my challenge is a little different because there will not be 2,000 Republicans running for the presidency in 2020. There will likely only be one. And so the question was to think about how conservative leaning health reform goes given the experience of 2017 and given the fact that there's still a considerable amount of disagreement within the conservative movement, the conservative policy community, regarding the best way forward on healthcare. And let me just start also situationally by saying that I think the error of a lot of analysts in thinking about what happened in 2017 was to posit that somehow Republicans had an insufficient number of ideas regarding health reform. I think quite the opposite was true. In fact, they had too many ideas, many of which probably weren't very good, but they had a number of ideas, and the number of ideas spoke, in my mind, to the lack of resolution amongst conservatives regarding how best to approach healthcare policy. So I begin the paper by trying to think about some of the key debates, if you will, within the conservative movement when we think about healthcare policy. And I think it's important to articulate this and really call them out because I think understanding these debates will help people understand why it is that Republicans have struggled in fits and starts to address some of these healthcare issues over the years. The first question is one that many may think is settled, but in fact amongst conservatives is not, which is whether universal coverage is in fact a meaningful goal or desirable goal at all. I think some conservatives would make the argument that universal coverage entrenches a highly inefficient and ineffective system, and we ought to think about the architecture and the structure of the system to begin with, and whether in fact universality is a useful metric to consider as policymakers try to evaluate different options is a debate that has arisen at various points over the conservative movement. I personally take the view that universality is an important goal, not for the least of which reasons is probably the only one we have that we can all generally agree on as being reasonably important. And so this is a debate then that animates the conservative disagreement on this issue, because you can understand why some might not put as much import into coverage numbers produced by CBO or other analysts, for example, as others would. And it's precisely because there's a disagreement regarding the efficacy of universality as a goal. Secondly, there's long been disagreement regarding how the tax code ought to be used to subsidize coverage. Now, obviously, as we all know, the tax code is a big part of the healthcare system now. It goes back many, many years, many decades. And so Republicans have had this disagreement at a very basic level about whether to use, for example, tax deductions or tax credits to try and improve the levels of coverage. Now, this might seem like a relatively minor debate to you, but it's actually one that's caused a lot of hurt feelings amongst different conservatives when people are told they want to go in one direction or another. Speaker Ryan has been a big advocate of the use of tax credits. Others, like former Governor Bobby Jindal, have been advocates of using a flat standard deduction type approach. And this sort of internecine warfare over the tax code has actually been a big component of conservative health reform discussions for many decades now. And so to a certain degree, the challenge in looking at health reform now is how do you transcend that very traditional battle between how the tax code is used in a very narrow way to subsidize increases in coverage. The third question, which is one that really came to the fore during the 2017 debate, is the balance between consumer empowerment and initiatives to boost choice in the marketplace and insurance regulations that are designed to be consumer protections, and the role thereof in terms of balancing the federal role versus the state role with respect to these questions around how to address consumer facing or consumer promoting regulations versus ones that are promoting of choice and potentially reducing cost. And so you saw toward the end of the debate in 2017 an effort by some Republicans to place much more authority for those kinds of questions back at the state level. Of course, the detriment to that of what was a degradation of the guarantee with respect, for example, to coverage of those with pre-existing conditions in federal law, and that created a whole host of political problems that we need not rehash here. But certainly, I think the question of how to balance the regulatory effort between state and federal, and then even at the federal level, how to sort out some of those questions remained a source of significant debate. You had some in the U.S. Congress, for example, who were much more insistent, Rand Paul comes to mind, who were much more insistent regarding the need to devolve all of this regulatory authority to states. And you had others like Susan Collins, who were much more insistent on retaining some level of federal protection. The final sort of debate I would sort of outline for you is the question of what to do about the Medicaid expansion. And this goes to a long-standing question amongst conservatives regarding the efficacy of the Medicaid program. Is the Medicaid program really the best way to cover those who it covers currently? And obviously, this was exacerbated by the ACA's massive expansion of the Medicaid program. What we saw in 2017, though, was a rift developing amongst Republicans, particularly amongst, let's say, more centrist governors like John Kasich, as well as more centrist members of the U.S. Congress, centrist Republicans, and those who believed that a full-scale assault on the Medicaid expansion was a reasonable way to proceed. And beyond that, certainly many of the Republican efforts in 2017 actually went to fundamental redesign of Medicaid, even for traditional Medicaid populations, which turned out to be also politically somewhat unpopular. And so the question of what to do about the Medicaid piece is actually quite fundamental, and this debate within conservative circles is a more recent one that was really brought on by the 2017 repeal and replace efforts. So in this context, the challenge is, first of all, articulating what is the conservative framework going forward, and secondly, how does one improve upon past articulations of that framework? So to the first question, I sort of elected to talk about the state innovation approach for a few reasons. First of all, because I wrote the paper, I got to choose the approach I liked the most. So there's that. Secondly, the reality of it is that Donald Trump is probably going to be the Republican nominee in 2020, and the president has articulated in the form of his fiscal year 19 budget an adherence to the state innovation approach, which most recently was an amendment proposed by Senators Graham, Cassidy, Heller, and Johnson at the end of the 2017 debate, which was never formally voted on. And because it was never formally voted on, it was never formally rejected, unlike other approaches, and so therefore I think it has somewhat more of an air of probability just simply because it wasn't rejected in its form. But the third reason is one that I think is more fundamental, which is that if you think about what ties most conservative people together, and from an ideological or from a theoretical perspective, the value of federalism usually ranks quite high on the list of why conservatives self-identify as conservatives. And so as a result, my belief is that the advantage to a state innovation approach is that it starts from a theoretical premise that at least most conservatives should subscribe to, which is that we'd like to figure out ways to better empower states to expand healthcare coverage that suits their citizens best. And as a result, the state innovation approach, I think, has a certain elegance to the way in which it adheres to or responds to that core and fundamental tenet within conservative thought. So for those reasons, what the rest of the paper proceeds to do is to flesh out what I think are some key questions that policymakers ought to evaluate as they seek to improve upon and innovate upon the state innovation approach that was outlined by Graham, Cassidy, Heller, and Johnson. So some of the questions that I ask and attempt to answer are, first of all, and I think this probably is the most important one to a certain degree, certainly politically it is, which is how does conservative reform in this vein enhance affordability and expand accessibility to coverage? And part of the challenge here, obviously, is that when you leave this sort of formulation in the hands of states, it creates lots of different opportunities for states to do lots of different things with the money that they get. But if you return to the premise that really states ought to be essentially required to use this money in two ways, one either, and ideally in both, one is to lower premiums in the marketplace generally on the individual market, and the second is to specifically subsidize those who are low income and or who have pre-existing conditions that force their premiums up. The question then becomes, are there specific approaches that states can use to get at and subsidize these populations? Some of it goes to risk mitigation strategies like reinsurance. I propose potentially looking at mechanisms like automatic enrollment in plans that could potentially increase the nature or improve the nature of the risk pool. But certainly the first question is around coverage, affordability, and accessibility. The second question is around the size of a state's block grant and how that's determined over time. Obviously, it makes a big difference if you inflate a block grant based only on prices versus on medical inflation versus on medical inflation plus some factor. And so I explore some of the challenges in different formulations of how that block grant might be determined over time. And I suggest that maybe states ought to consider, the federal government ought to consider telling states that really one of the ways to focus this is to think about spending on individuals who fall within a broader definition of poverty, let's say between 50 and 300% of the federal poverty level, rather than between 50 and 138% of the federal poverty levels established by the ACA. I also ask about whether these proposals going forward ought to address the traditional Medicaid population at all. I can answer that pretty simply, no, I don't think they should. I think it creates political hazards, although in the long run, it's probably not as fiscally responsible of a solution. I can safely say that all the fiscal hawks have flown away from Washington anyway, so this is of less importance. A few other questions which I think are significant, and then I see my time is coming to a close. The first has to do with this issue of whether states should be required to adhere to all of the ACA's regulations. And this is a tough one because, as I noted earlier, there is significant disagreement amongst conservatives regarding what the best approach here is. And I suggest some middle ground might be best, where on the one hand, states would be allowed to opt out of certain coverage mandates or cost-sharing limitations, but certain ACA protections, for example, guaranteed issue protections that help to preserve coverage for those with pre-existing conditions probably will not go anywhere. And the question is whether states can feasibly work through this patchwork of regulatory changes that might happen given the circumstances. Finally, I'll just say that there's a question about whether state-based assistance should be usable on the in venues beyond the ACA marketplaces. I tend to think this is a fairly important one for conservatives who would like to see more general applicability for premium assistance outside of just the marketplace setting. One might ask, for example, whether such premium subsidies could be used to offset the cost of employer-sponsored offers of coverage or into the Medicaid program itself, COBRA coverage, short-term limited duration coverage. I tend to believe and take the view that a broader net is better than a more narrow one, and HHS has recently, CMS that is, has developed competency that would allow a broader application potentially of premium subsidies outside of the ACA marketplaces, so I think this is something that's worth trying. The bottom line here, and I'll just wrap up by saying that it is highly unlikely, obviously, that Republicans, I think, take another pass at health reform in the very near future, which is not to say that after the 2020 elections there won't be some effort to do it, in part because one of the things that the 2018 campaign exposed is the danger of not really having a great answer when it comes to the question of how you plan to deal with health reform going forward. And so I would suggest that the state innovation approach provides a more plentiful opportunity for Republicans to have a set of solutions that they can at least point to and say, we've thought through some of the ways that this might move forward, and still adheres to some of the core tenets that I think most Republicans would hold onto as tenets that they believe public policy ought to advance. So with that, I will conclude.
Those were outstanding presentations of very complex material. I'm going to ask my 4 respondents to come and join at the table, and just to explain to you in the audience how we're going to go from here. We've identified 4 people who will give some brief, prepared responses, and then we'll have a conversation which I will lead, and as I said, I'll start off with some of my own questions and we'll bring you all in after. But we have a significant amount of time devoted to discussion here. We're going to hear from Rodney Whitlock, Vice President for Health Policy at ML Strategies, with 20 years of experience working in Congress, a health policy advisor and acting health policy director for Finance Committee Chairman Chuck Grassley, was on the staff of then U.S. Representative Charlie Norwood. We'll hear from Adaeze Enekwechi, Vice President at McDermott Plus Consulting, who was until recently the Associate Director for Health Programs at the White House Office of Management and Budget. Meena Seshamani, Assistant Professor in the Department of Otolaryngology. Oh, I did just get off an airplane. Otolaryngology, head and neck surgery at the Georgetown University School of Medicine. Third time was not a charm, but she was formerly the director of the Office of Health Reform in the U.S. Department of Health and Human Services. Josh Archambault, senior fellow at the Foundation for Government Accountability, has served in the Center for Healthcare Solutions and program manager at the Pioneer Institute in Boston, and worked as legislative director in the Massachusetts Senate for Scott Brown, senior legislative aide for then Governor Mitt Romney in the Office of Legislative Affairs. So we're going to cover a lot of ground in a short time, get a bunch of issues out on the table, then we'll try to work it through. I'll just stay up here while you all get started. Rodney, you want to kick us off with some comments?
Sure. I want to start by saying that I don't want anything I'm saying to be interpreted as critical towards either Sherry or Lanhee. My opinion is that they were asked to make rock soup, and the only thing people gave them were rocks. So I think, looking at where we're going, I'll start with Sherry's first. I think one of the things to look at is effectively, what do you want people to hear in where they're going, which is the problem is the price. Words, words, words. So we need to look at price controls. Words, words, words. We need to think about administrative prices. Words, words, or some sort of reference pricing. Words, words. Maybe all-payer rate setting. Words, words, words. What do you want people to hear? And that's going to be the challenge for, I think, Democrats in 20 and ideas like the direction you're going there that you sketched out. You have to decide how much of a fight do you want to have. Because you can use lots of words to make sure people don't actually fully understand it, or you can go straight into it and let people know where you want to go, understanding there will be consequences. And I think that's the challenge that right now Democrats have largely been able to do the Republican version of a 3-word slogan, repeal and replace, with a Medicare for all. But eventually, if you define it out, you're going to make enemies. The Lyndon Johnson quote was perfect, and that will be the case in anything that's designed that way. Lonnie's piece was wonderful for capturing the reality of Republican ideology in healthcare. 2010 broke Republicans. Prior to 2010, you were allowed to think that the federal government had an appropriate role in designing and determining the playing field for private entities to compete successfully to produce the best product for individuals. That was actually a totally reasonable position for Republicans to take. Romney in 06, Bush in 07, McCain in 08. After 9/10, Republicans were effectively broken on that. And since, you've seen Republicans devolve into what I lovingly refer to as confederal anarchy, that the approach generally is it shouldn't be done by government, but if any government should do it, it's probably the states that should do it. And you've seen that now become a much more dominant threat. And the problem is, for Republicans, is articulating how you achieve anything remotely close to what is existing policy by going that route. And nothing captures that, from my perspective, any better than the conversation about pre-existing condition protections. That if you want to convince someone that you're actually taking care of people with pre-existing conditions while devolving authority to the states, that now make a convincing case that you're in any way, shape, or form doing it as well as existing law. I'm fairly certain I just heard Jeanne explain to you how that's an abject failure. Now, go run on that. And that's the problem I think that a lot of Republicans are going to face going into 2020. How do you deal with that dynamic of, if we're going to actually say that we're doing things that we stand for, we're going to have to actually step up and do some things. We're going to have to be able to do it, say we're going to do it at a federal level, or we're going to have to be able to coherently make the case that that what we are doing and how we are doing it in a different mechanism is remotely viable. And that's the challenge, I think, in Republicans' ideology as it has moved to a more state-based approach. So I'll pause there and turn it over.
Terrific.
Oh, I get extra time.
I'll take it.
I didn't say that.
Well, thank you, Alan, for the invitation and for an opportunity to share a few thoughts. I have general comments across the board because that's what we do. I think for me, one of the biggest takeaways over the last 2, 5, perhaps even 8 years is the importance of communicating policy impacts in a clear and effective manner. 2017 and 2018 have been sobering years for policymakers who were under the impression that voters are not paying attention to healthcare policy. Bad policies that threaten to take away what people already have or that degrade the quality of what they're accustomed to are not tolerated by the electorate. I think that's one key takeaway. So right now, I believe we have an opportunity to use evidence and data in making policies. I'm a health services researcher. Jeanne wanted me to make sure to talk about evidence and evidence-based policy making. So while the evidence we have may be imperfect, we cannot let the imperfect data that we have or ideology, quite frankly, get in the way of making the best policies that we can for the American people. So with that in mind, I have a few areas where I believe we should focus our priorities in 2020 and beyond. The first is protecting the integrity of health insurance coverage for individuals in the exchanges. So legislative efforts to repeal the ACA all failed in 2017, and new efforts, I think we all agree, are unlikely in 2019. But we can expect to see attempts to chisel away at protections in the ACA. Policy analysts and advocates must watch for these policies when they land through rules or administrative action and articulate very clearly any deleterious effects that may be present, if there are any. So for example, short-term limited duration plans that erode protections guaranteed as part of essential health benefits will prove damaging to individuals in the small group, non-group market. And plans that do not cover maternity care or other women's services often leave families exposed to significant financial burden when there's a major life event like a pregnancy or birth. And we have data on this. We don't guess at these types of effects. So Medicare for all, since that's on the table, and public insurance plans are very attractive to many, perhaps because there's something attractive about simplified set of options. Also, it protects against the uncertainties in the individual market that have been introduced more recently, at least notionally. So it may feature prominently in a 2020 Democratic primary, but the cost of such proposals will likely shorten meaningful conversations around the merits of such policies. I feel duty-bound to say that as a former CBO and OMBer, because we haven't had those conversations fully in the public domain yet. The second point I'd like to raise is ensuring that Medicaid services serves the intended population. So in the near and medium term, a number of states will likely expand Medicaid or at least have significant policy churn in those states, Idaho, Nebraska, Utah, because we put it to a vote in those states, Kansas, Wisconsin, Maine, and a couple of others because we had changes in the State House. The overwhelming number of people who will qualify for Medicaid due to expansion will benefit from having health insurance and regular access to care, many of them for the first time. Adding administrative hurdles like work requirements will likely not stop in the next couple of years, but we will likely see increased scrutiny of these policies and how they are implemented and enforced in states, especially after Arkansas, I think in the last week, kicked off about 8,500 people, and as of yesterday, added another 3,000 people who will be kicked off of the Medicaid rolls. This is for a program that is designed and created to serve the indigent, and for which the federal government still contributes quite a significant share. The third point I'd like to raise, because in health policy, we don't just limit ourselves to thinking about coverage and coverage policies, is addressing social determinants of health among seniors and other vulnerable populations in community settings. So to my surprise, it was a surprise to many in 2017 that any plans to block grant Medicaid would slash funds for long-term care patients, long-term care for seniors. Medicaid funds roughly 70% of expenditures and services for nursing home care and long-term care more broadly. The budgetary significance of the program at the state level is hard to overstate and even greater for families. Yet, the significant variation in quality, cost, and availability in long-term care services remains an area often unaddressed in national policy discussion, and quite frankly, discussed in detail at a pretty cursory level in states where they're often implemented. This is coupled with recent recognition in policy circles that social determinants of health drive a significant portion of our healthcare costs, and that if we address some of these social needs, we create an opportunity to drive down costs and improve health in a way that matters greatly for people. So we have a unique opportunity now to put this on the agenda in 2020 and beyond, and to think creatively about how to realign incentives and create a system that works for seniors, for mothers, children, and other vulnerable populations. I suspect in the near future, I know my time is up, just 30 more seconds. In the near future, we will likely further refine the evidence base for implementation at scale, because this is what we've lacked in the past, and build on what currently exists from smaller programs around the country. But this is an area where I feel very strongly that we have an opportunity to really build capacity and as well as evidence. There are several other things I could put on the list. We've got drugs, we've got AI or artificial intelligence, technology, opioids. I'm sure we can talk about all of those. But for now, these are the 3 points I'd like to highlight as areas where we want to spend some time focusing and getting on the agenda in 6 months, since it sounds like we'll be talking about this in 6 months in Iowa. Thank you.
Thank you. Meena.
Great. Well, thank you first to Alan and Jeanne and David for inviting me to come join this discussion. And I also want to thank Sherry and Lanhee for 2 very thoughtful and very thought-provoking papers that I think have really laid a good framework upon which to discuss the policies that may be emerging going forward. I think Jeanne mentioned that Adaeze Sen and I have a paper coming out today in the Commonwealth Fund, with the Commonwealth Fund, talking about delivery system reform and how that gets integrated into some of these proposals that are being put forward. So I thought I could share a bit about that in the 5 minutes. If you want further details, you can go to the papers. And I'd like to start off with something that came through both Lanhee and Sherry's remarks about the problems that people currently see and how that will then translate into policies that are developed. And as is not a surprise to all of you, I am sure, it's that iron triangle of cost, quality, and access. And delivery system reform is really at the heart of all of that, and so therefore should be incorporated in anything that is considered moving forward. And in thinking through how we drive value in the healthcare system, there are kind of 3 areas that are very key for making sure that things can move forward. The first being information sharing and infrastructure. The second, having flexibility for innovation. And the third, having alignment and sustainability of efforts and stability. And so what I'd like to do is, with each of the proposals, the state-based innovation and the public option proposals, is talk about one area in those 3 for each of them for consideration moving forward, where perhaps there's some room for improvement and further development of policies. So first, with the state-based approach, I think just state innovation approach answers right there, that there's a lot of room for flexibility of innovation. States are more on the ground. There's huge variation in populations, in markets, in geographies, to really enable some innovation around how providers and payers and patients work together to deliver care. But I think the flip side of that is the alignment and the stability of efforts. Providers, for instance, oftentimes do not function in just one state. And to have multiple different states with multiple different quality metrics, multiple different payment proposals, it can really engender a lot of confusion. And I think, as all of you know, one of the clear ways to make sure that no progress happens is by confusing everyone with 50 different options. So really being able to have some more alignment and stability is going to be key. And along that point, being able to have that alignment so that you can best assess what are things that work so that you can then scale those things that work. If you have 50 different laboratories, where is the avenue for sharing of best practices and diffusion versus just having 50 different laboratories? I think the third point I would make here is, traditionally, states have not always been at the forefront of innovating in the delivery system reform space on their own. A lot of times, they've done it with Medicaid managed care partners, for instance. And I think it remains to be seen, to the point that Lanhee made about how these state block grants are funded, what is going to be the role that managed care organizations or other payers or providers are going to pay depending on the dollars that are available and at stake. And so that is also something that is important to consider in this regard. Moving to the public option side of things, I'd like to focus among those 3, the information, flexibility, and the alignment and stability, on the information side. Because I think, as you all know, and as both Lanhee and Sherry spoke, having something that's more nationwide is going to engender alignment. Medicare has been at the forefront of doing some innovation in payment and having some flexibility with different types of programs for different areas. I think information is one area where a lot of times, in terms of information exchanges, states have taken a leading effort in creating information exchanges. And when you think about engaging multiple payers, because if you really want to have good sharing of information across different aspects of care and across the different payers that in different claim settings that a patient may be touching, really being able to engage all payers in creating that information infrastructure is going to be key. And so public options that are focusing more on just the Medicare side may need to think about how to engage private payers and providers through Medicare Advantage, through marketplace plans, through other avenues, to be able to make sure that you are still getting that engagement across the spectrum, both of the settings of healthcare and the players in healthcare, to be able to get that good information exchange for enabling shared decision-making and improvements in our care pathways across the continuum. Thank you.
Thank you. And Josh?
Great. Well, thank you so much for the invitation to share my thoughts. My wife and kids appreciate it because otherwise they hear it at the dinner table every night. So, the way I approach this when I read the papers is I put things into buckets. What do I agree with? What do I disagree with? And what do I think is missing in the analysis? And I have 5 minutes, so I'm only going to give you just a couple of those. First of all, I just want to underline in Lanhee's paper a number of the divisions, disagreements, fractions that he underlined in the paper within the conservative movement. They are very real, and they play out in very heated discussions, and also people feel like it's the building blocks by which you take the next step. So I think he's absolutely right to highlight those, whether it's the tax credit reduction. Those are very real ongoing discussions going forward. Also, when it comes to Medicaid, how you structure those, and just for background for those that are not familiar with the Foundation for Government Accountability, we're a relatively new think tank, been around for a few years, but our niche has really been at the state level for years. We're active in 35 states, we're active here in DC too, but we're largely informed by those conversations at the state level. And I'll tell you, in 2017, when the repeal and replace discussion played itself out, after maybe revision number 2, on how it would impact states on their Medicaid budgets, governors were like, forget this, I'm not running the numbers again until I know what's actually going to pass, and then I'll figure it out. So when it comes to a conversation about state innovation for Medicaid or for private insurance, they're burnt out, a lot of them, when it comes to this. So I don't expect to see a lot of governors stepping forward saying, I'll be the first to come up with proposals, because they really want to know what the guardrails are before they step out. As far as what I think candidates are going to run on in the Republican side, I don't think they're going to run on any congressional proposal. In fact, I think they may run away from them. I think they're going to run against drug companies, against the insurance companies, and they probably will run on transparency. If I were a candidate running for president on the Republican side, I would implement some sort of incentive program for Medicare patients, for federal employees, that pays them to shop, and talk about how that's the future of healthcare, because it's a very big contrast to the public option type conversation that's probably going to be happening on the Democratic side. As far as kind of whether they have to deal with the issue of pre-existing conditions, sure, it will come up, but I actually think how successful short-term plans and association health plans are could tamper down this conversation quite a bit. The dynamic that I'm seeing in the marketplace is that the subsidized population is relatively stable, maybe going down a tiny bit. It's the non-subsidized part of the ACA market that is really shrinking. And those people, when I go to the states all over the country, that's the conversation they're having. I simply cannot afford a product. That's the problem that they're having. And so I think this conversation about pre-existing conditions might get a little bit smaller. And you may have some states say, look, just turn that into something that looks like a high-risk pool, segment them off, split the risk pools, and we'll talk about affordable products, we'll talk about reinsurance, we'll talk about invisible risk sharing, which some states have done in the past to try to offer much more affordable products for those individuals. I'll just switch over to the other paper. I thought Sherry did a really nice job highlighting some of the issues that are out there. She cited a survey talking about affordability for non-subsidized populations, as I just mentioned, and a fear of losing providers. Well, I'll just mention short-term plans address both of those issues directly. So just to underline that what the public is saying they're concerned about, there are things coming onto the market that get to that. Since I live in Massachusetts, I'll just mention something about Medicare for All, because it's a conversation that is very much bloomed in our state, and I think is anticipate going forward. A couple things. The first thing is, I actually don't think it's as popular. More people, as they learn more about it, and it's going to be the challenge for Democrats, they don't like it. They also get really nervous about legislating through government control. We had a nurse staffing ratio ballot initiative that started with wide support when it first got on the ballot, and it lost handily. And so I think that when you come to talk about how does Medicare how does it work out for kids? Oh yeah. How quickly are you going to transition into this program? And oh, by the way, we are going to ban your private insurance. These were all mentioned in the paper. I think it makes the political lift so much more difficult. However, politically speaking, at least in Massachusetts, I know in California to a certain extent, there is significant pressure on Democratic candidates to endorse that position and not this hybrid approaches that are on the market. So whether somebody can kind of straddle the fence and in the primary say, yes, I'm all for this, and then switch in the general, that could be what happens. But that is, I think, the dynamic and conversation that you're going to see itself play out. And the public in general, the more they learn about it, the more they don't like it. Thanks.
Okay, we have a lot to cover, and I really like all the issues that were teed up. What I want to do is not make this sort of a bombarding Sherry and Lanhee with a zillion, why didn't you do this, or what do you think about this? We have a panel, but what I'm going to do is sort of one by one bring out some topics, encourage our authors to maybe take a cut at them, but also definitely encourage the others of you to participate. Sherry, I'm going to start with you since you came up first. You, in setting out these sort of in your introduction, you talked about sort of two streams, responding to specific problems as well as building a particular vision. And then, as you said at the end, when you start looking at your three choices, I don't just mean you, people get nervous, Josh just mentioned it, at disrupting coverage for 175 million people. It starts bringing you back politically a little bit more toward the first, maybe the second, but more the first of building in what you might think of as public features into private coverage. So I went back to your list of the problems that people state that they have, which is what you said at the outset: cost, premiums, deductibles, cost sharing, out of network problems, the size of networks. Now let's think, what is a viable sort of public features approach to harness the private sector to address those kinds of things? How realistic is that? I'm thinking of the evolution of the pre-existing condition exclusion, eliminating those provisions. Started with some states adopting it, then we get HIPAA, then we get the Affordable Care Act, putting some affordability boundaries in it. Is it really realistic to imagine building a public model, if you will, that address these problems of premiums and deductibles and cost sharing and network adequacy? What would it look like to make that transition?
So I guess I'm not sure it would be much harder than building Medicare Advantage into traditional Medicare, right? Kind of coming at it from the other end. So Medicare Advantage is adding more market features to a fully fee-for-service government-operated program and it started very small and grew over time. One can imagine, I'm not saying this is the right way to go, but one can imagine developing a highly regulated public option model that you put in the marketplaces. Just say that's one of the things we talk about. Imagine starting it relatively as a small thing that is out there, that is a more regulated plan, and see what happens.
So what I'm hearing is you build it out from the public side, not so much adding expectations to what private coverage looks like.
Or we have done that too. I mean, I actually think this is something we have done in many places already. So look at Medicaid managed care. There we start by saying I guess we were starting from the public side there in some sense, but we were asking managed care companies to meet a lot of requirements, and we do it. So we could do this from a regulatory perspective as well. It's not easy, but it's certainly something we have done before.
So none of it's easy. We'll stipulate to that. But I guess, and maybe I'm misreading a little bit, I am looking for examples coming from the private side. So it's one thing to take Medicare traditional and open up MA. It's one thing to take Medicaid fee-for-service and say we're going to rely more on managed care. But what I thought I heard you say is that one of the potential ways forward is to have what I read as sort of public features of private coverage.
Right, so
the example of that I can think of most clearly is HIPAA on pre-X, but I can't think of a lot on coverage mandates.
There have been coverage mandates at the state level forever and ever. We've had a long history of doing that. So we've had look at New York State. We've had community rating and pre-X and guaranteed issue. Not saying it worked really well, but we did it. So certainly there is history of doing this on the private side.
So the idea would be to take some of that national and to say...
Right, and to offer a more coherent, just to tighten up the ACA requirements more and just go from there. So I think we've done it.
Any reactions from others? Am I on a a topic that didn't resonate with anyone else? Or?
Well, I think you kind of already took it national, did you not? I mean, you passed the ACA, so I guess just my question a little bit is we've had this experimentation with basic health plans and co-ops, and I mean, is that a fundamentally different approach to what you're proposing, or is it something quite similar?
It could be something quite similar. I mean, we're not proposing anything particular. We're saying that there are a range of strategies that you could take, and I think the basic health plan option would be one of them.
So loosely, two strategies that are significantly less disruptive than a Medicare for all. One is to start small with something public, regulated, and see where it goes and build out. The other is to look at what's in the private market and say private coverage along the lines of the ACA needs to meet certain standards, more standards than it's meeting today.
We also do it, so another example might be the regulations around high deductible health plans with HSAs say this is what you have to get this thing. We could, we could say in order to get the ESI tax credit, you have to have a plan that has a deductible that is less than X. I mean, so there is, right?
Yeah, and I don't want anyone to be nervous when you're putting options out there that we're going to put those words in your mouth that's what you're for.
These are not played out, but we have a very long history of regulating at every level in both the private and the public sectors here, and we could just develop those regulations further.
Yeah. Okay. Lanhee, I want to follow up on something that I think Rodney alluded to, and I'll push a little farther. I'm thinking that given the way the budgeteers look at legislative proposals, any block grant structure that reduces the rate of growth, which is pretty central, I think, to the Republicans who are supporting it, is going to analytically show reductions in coverage. Conceptually, you and others have talked about flexibility, innovation, delivery system reform, and conceptually the goal is to encourage states to embrace that. But we know that the budget analysts basically don't score those things, at least that's what I've observed. And so you're stuck politically with a pretty big target that says this structural change leads to this many people losing coverage. So how do you think about that in a political context to align what you hope will happen with what people will say will happen?
Yeah, I mean, I think this is obviously the central political challenge, I think, of the approach. So what I would say is, I think, first of all, the repeal of the individual mandate by the tax law in 2017 does change the scoring dynamic. Now, how much and how impactful, and now are we in a debate about 10 million versus 15 million? I'm probably not the best person to judge kind of what the acceptable coverage loss number is, if you will. But what I would say is, first of all, I think the dynamic around the debate was altered by repeal of the individual mandate in a more favorable way when Republicans are thinking about what some alternatives might be. The challenge really is around how to capture some of this innovation in existing scoring conventions, and the answer is I don't think existing scoring conventions would be particularly amenable to your point, to capturing some of this. But the reality is, I think, what this approach can potentially do, if argued and designed the right way, is to present a focus on certain populations to whom assistance would be targeted and to whom arguably that assistance should have been targeted more closely in the ACA. And so the issue of coverage loss then becomes a broader question of who exactly is losing coverage and what do those populations look like. It's problematic if, for example, the coverage loss traces directly to people, for example, who have very costly pre-existing conditions. That would probably not be a political advantage for anyone proposing this. Which is not to say that some coverage loss is more acceptable than others. It's just to say if you're talking about the pure politics of the argument, I think who loses coverage matters almost as much as how many lose coverage. And so I think it's I think it creates some challenges, but in the world we live in now, post-repeal of the individual mandate, I do think that the dynamic has changed.
If I can
Yes,
add some thoughts. I don't know if my mic is on, but I think the issue around block granting Medicaid highlighted what I think is a fundamental problem with the policy. I don't think that it's a question of people not understanding or a lack of discussion around innovation or how CBO scores innovation. I think there's just a fundamental problem with the policy. And the reason I state that is that once you block grant Medicaid and move away from current state, we have to just acknowledge that it does mean we have fewer resources, less money going into coverage. People will lose coverage. I don't see or understand, I haven't seen any analysis that shows that coverage losses would be circumscribed to a particular group by any, that you define by any characteristic or any measure. And so I think it introduces a problem immediately at the state level. The reason why these are not scoreable right now, even theoretically, is that I haven't seen one single state governor, state Department of Health, or health commissioner, or any other state level actor say that if I have less resources or fewer dollars to work within a Medicaid program, here's how I'm better off. Here's how we will innovate our way out of that fundamental problem. The demographic changes in terms of more people, risk, higher acuity patients or individuals in the Medicaid program, older adults growing in that space, just doesn't compute. When you have fewer resources, again, we have not seen anyone innovate their way out of that basic problem. So I think it's helpful to sort of table those facts, and we don't twist ourselves into a pretzel coming up with different words to characterize what, quite frankly, is the problem. Fewer resources for more people, higher acuity, greater set of problems, and there's just no way to innovate our way out of that.
So let me just push back a little bit on this analysis. First of all, I think one of the points I make in the paper is that I do think if we're trying to figure out the best route forward for this, we do need to separate out the traditional Medicaid population from the expansion population. So what I propose is that future activity ought to be limited to the expansion population. If we're looking at the expansion population, I would make the argument that I think some states have at least conceptually thought about, and I would point to Arkansas as an example, some states have thought about how you take people who have been newly made eligible for Medicaid and consider whether there's a coverage mechanism or some way of subsidizing coverage on the exchanges that might be able to meet their needs. Now, the financing question, I agree, which is why I spent some time thinking about the growth of the grant, because I agree that compressing the growth of the grant too much creates significant problems, which, beyond being political issues, I agree are going to create policy failures. But I would sort of put an asterisk by it and say, I think if you're able to cleave the expansion population from the traditional population, I think it addresses some subset of these concerns.
Okay, so just before you jump in, Meena, I'm going to do everything I can to avoid this being a debate over the merits of block grants or Medicare for All or anything like that. There will be 2 years to have that debate. What I'm hearing from a structural perspective is that it's possible to look at the constraints in Medicaid through two potential lenses. Lanhee, you were very clear at the outset that the question of whether everyone should have coverage is not a settled matter for some on the more conservative side. And so one possible argument with respect to constrained growth is that the people who will lose coverage are the people who are less in need of help getting coverage. I'm not trying to put words in your mouth, but I think that's part of the question, is who's deserving. But the other is the claim, and I think it's one that we could argue about, but the claim that relief from various rules and regulations creates opportunities for efficiencies. So Meena, I want you to jump in, but I also want to sort of tee up this question of, having worked with states for many years, there's been this longstanding sense that accountability for Medicaid shouldn't be a dollar match at the federal level. It should be for the outcomes. It should be the health of the population. Is there a positive policy and political message in federalism that talks about shifting what the federal government's support for states is away from matching dollars toward promoting outcomes? Yeah, but I didn't mean to jump over you, Meena. But go ahead.
No, that's okay. I mean, in part, you mentioned where I was going to go, which was, I think there is a fundamental issue with scoring. It is blunt, right? So to the coverage point, well, who really needs coverage versus who doesn't? That could be a whole other conversation. But to take it to care, if we're trying to improve value and increase consumerism, well, are the decisions being made affecting needed care, or are they affecting superfluous care that, everyone would say, yes, that care wasn't needed and those dollars shouldn't be spent? And I think, taking the example of, HSAs and consumerism, right? We have a healthcare market. I'm a health economist, so I'm going to nerd out now, but we have a healthcare market where you have moral hazard, where people don't feel the economic effects of the decision they're making. And you have information asymmetry, where people don't know how to even make those decisions because they don't have information on cost and quality, and patients haven't gone to medical school. And to be able to invest in things like information so people can make decisions, which can then maybe demonstrate some change in, in care that's provided, how do we, coming back to the scoring issue, say, okay, so if increased consumerism led to a decrease in services, was that a decrease in a way that we want it to be? Or was that a decrease in things that really shouldn't have been decreased? And I think the discussion here highlights the very blunt nature of scoring in how a lot of these policies end up getting developed and evaluated.
We have a few examples, and I'll just maybe name one where we've tied, how we think about the success of the program is less about federal expenditures and more about outcomes. So one example is the financial alignment demonstration, where, again, that was for those who don't know, it came out of ACA, obviously, through CMMI. But it's basically, I think initially there were 10 states. And we were really focused on bringing people who have not had the experience of health insurance coverage into the fold, looking at ways of reaching out and engaging in really creative ways these individuals, getting them to see their physicians or nurse practitioners or whomever for primary care. Thinking about ongoing engagement, certainly looking at a variety of health outcomes. Again, not tied to how much is the government necessarily, how much is the federal government spending on this, but the intent, absolutely the health-related intent of having health insurance. There are a few others, but I think that that's one concrete example to answer your question.
So I'm a little confused. When I think of the financial alignment initiative, I'm thinking of dual eligibles. And is that what you're?
Yeah.
So
yeah, it was duals.
I'll just say people I talked to saw this very much as financially oriented, obviously with the goal of improving care. But it's not people without health insurance. It's people with two different programs that haven't played well together.
Right.
But trying to change the care. The point is the importance of changing care delivery. I guess you could use ACOs as another model. There are outcomes that you have to measure. Sherry, you want to?
I mean, let me go back to your question, which is, should we move to a system of reimbursing, of sharing resources with the states based on some outcome-based statistics? And maybe 30 years from now, if my students do really, really well, that would be something we might want to consider. At this moment in history, given how much we know about how the structure of Medicaid programs affects outcomes and how so many other things affect outcomes, I would be pretty nervous about going down that path.
And now I'm going to pull a Sherry and say, I didn't say should.
Right.
I just wondered if
right.
there's a
so
a
I
positive.
think this is something we could study for a
Yep.
long time, and we could imagine doing some small efforts in this direction for particular places where we thought we knew how to make a difference and states could invest appropriately across the board. I mean, we've been doing this for a long time around hospitals, and I don't feel very confident there yet, let alone a really low a population with a lot of socioeconomic challenges. I would be very nervous.
Rodney?
I think scoring is really a thread here that I'd like to pull a little bit here. So if you're an insider CBO geek, you're following the interactions between CBO and Senator Enzi, as current budget chair, talking about, okay, what is the now new scoring world post-individual mandate? Because if you look at it from 2009 through the repeal, CBO had a certain belief. I mean, and I think many of you in the room have heard this one, which is, I hope for you that someone in your life looks at you the way that CBO looks at the individual mandate. All right, well, now they don't get to do that anymore, and they admit it. And so post 2017, the repeal, where we are next is CBO will treat future efforts as there's an in of dollars, and if you want to take them and completely restructure them, that is available to you in a way that exists now outside the individual mandate. So if where Lanhee's been talking about, and I'll disagree gently with you here, Adaeze, that if you Republicans committed to keep the same in of dollars in the system and just look at a different way of redistributing them in a way to try to produce coverage outcomes, listen, I know there are a few of you in the room who will tell me, nope, there's only one way to do it. It was the ACA, it was the right way, and I'll slap you if you challenge it again. But maybe, just maybe, other people could look at it in a redistributive manner going to the states where that actually could be possible.
And this is a dynamic that I know you're full aware of. We have to remember also that governors are in a 1 to 2 year budget cycle, where in Washington, you're talking 10 years, right, typically, or longer. And so when I talk to governors and their staff, their main concern is that their Medicaid budgets are on fire. And so it's hard for them to think 10 years out. And so whenever Washington has a discussion, they need to think about state-specific impact and 1 to 2 year budget impacts. And I'll just mention, and I'll just throw this out, I'm sure not everybody will agree with this, but if we don't think that Medicaid expansion is starting to crowd out spending in a number of these states, then you need to talk to budget writers in states. It is a big issue for them, and if the public educators ever connect the dots at the state level, you're going to start to see a fight at the state level. And some folks, Governor Kasich, is no longer in office. So I think you're actually going to see a different dynamic. Even though you have ballot questions moving, you also have some others that have won elections that aren't as thrilled with the expansion and are seeing that crowd out and realizing that that might not be the direction they want to take their state in the future.
Sherry.
All right. I mean, I do think there is lots of evidence that suggests that Medicaid spending broadly is a real challenge for states. I think that if you actually look at the expansion, given the financing of the expansion and the number of federal dollars that flow into states off the federal match, it is very hard to argue that the expansion itself is the challenge for crowd out. Medicaid as a whole, for sure, is a real problem. But the expansion piece of it, the 90% federal dollars that come into the state is such a huge economic stimulus relative to the 10% federal state share that I think the math doesn't work.
Okay, I'm going to ask one more question and then open it up out here. I want to bring up a topic that feels to me has big implications for both of the proposals, but is not really discussed directly. And that's the growing body of literature and public understanding that provider consolidation is a major driver of price increases. And not to suggest that there are not also potentially improvements in care associated with coordination and investment in some of the infrastructure necessary to improve outcomes. But regardless of that, it is, I think, fairly clear to say it plays a role. So the question is, as you're thinking, when I think of both of your proposals, Lanhee, I don't see anything there that touches on this, and to say to states, go be creative, solve these problems, but there's this external force that you really have no control over. Doesn't seem very promising. And Sherry, short of the Medicare for All, which, you know, with rate setting, since you expressed the challenges associated with something that disruptive, it's hard for me to see where you enter this discussion in a way that addresses that, even though the first topic you mentioned that we're trying to address is price. And so anyway, I'd love to get your thoughts on how does the 2020 plan look different or should be different due to our growing understanding of the role in consolidation?
So I think it definitely increases the logic of having a larger public presence in the healthcare system. Consolidation, a little bit of consolidation is probably related to antitrust policy, but a great deal of consolidation, I think this is the key, is just a natural force within the healthcare system because of the changes in the way that we are providing care. So hospital occupancy is dropping. People are spending less time in the hospital. We don't need as many hospitals in many parts of the country. There are not going to be as many hospitals, and it doesn't matter how aggressively we pursue antitrust policy. So if you are in an area of the country where there is only one hospital, it is really hard for me to see an argument for using competition to keep prices down, because there isn't any competition. Now, maybe somebody can come up with some magic way to inject competition in a place where there is a natural monopoly. We've seen this before, but I think it's not, I have not heard anything. So I think there you're going to see more interest in using some forms of price regulation, probably looking at the kinds of price regulation that we have thought about in other completely different sectors of the economy where we have natural monopoly problems. But I think the argument for using the private sector to control costs is just silly in a place where there's no competition in the private sector.
Yeah, I mean, I think that the advantage to looking at it at the state level would be, and this is how the theory goes, is that you would be able to have states look more carefully at, and some states I think would probably go in a sharper regulatory direction than others, and creating that opportunity and venue then allows us to see what might work and what might not work. So that's sort of the first set of arguments. The second set of issues goes to, I think that, and some of this has to do with the way that some of these block grants might be structured, or the way in which the federal government might approach this, is to say, can we create some more incentives? Can the federal government create a bonus structure, for example? I'm just totally whiteboarding this. Can they create an incentive-based bonus structure, for example, that goes at this specific question of competitiveness in the marketplace? I think it's right to say that you do have natural monopoly in some cases. So the question is there innovative technology that can help get at that telemedicine, for example? Is there some way of innovating in the telemedicine space around financing for that? So I don't have a great answer to your question, in part because I think the problem is a little more intractable than perhaps what the framework will specifically address, but I do tend to think that allowing for some of that policy innovation would be a good first step.
Great. Okay, I have a long list of questions, but let's start up here. We'll go to the back. We'll come here. We'll wait for a microphone. We have, last I knew, well over about 150 people online, and we'll be archiving this, so we do want to know who you are.
Sure. But, so this is primarily for Lanhee and Rodney, but welcome comments from anybody else. As I think about the Democratic task in the Congress that's coming up, one is to develop a broad agenda on health care that will then be picked up in some way or influence the Democratic candidates and help develop a platform for the next election. The other piece is to see what they can do, and that may involve passing bills in the House that die in the Senate. The other piece is to try and figure out things that would make modest progress on addressing some of the things Sherry pointed out, which is addressing specific problems, either with the Affordable Care Act and the problems in the insurance marketplace or other issues. In the past, those efforts have often been kind of driven by Democrats, but with significant Republican participation that makes it possible to get them passed. That certainly happened on a regular basis dealing with Medicare and the Finance Committee. I think of other programs like Kassebaum-Kennedy, Patient Bill of Rights, CHIP. And I guess the question is, in this climate, after what's happened, how do you see the prospects for some cooperation between the parties on more technical fixes directed at specific problems in the healthcare system?
David, I'll jump in since I don't think I've heard these two words come out. Drug pricing is going to be utterly fascinating the next year or two until they go fully into political mode, just because if we haven't learned anything over the past few weeks, anything can happen right now. Anything can happen after IPI. Anything could pop out. So, I mean, if the president went and the Democrats suddenly became incredibly enamored with the concept of government negotiation, I mean, I actually don't know what Mitch McConnell would be doing other than saying, what? And how he's going to get in front of that. I mean, who knows where they could go at this point?
Yeah, I mean, look, I think, how do I say this without being glib? The Democrats have an existential crisis on their hands with respect to how they want to pursue these next 2 years. And I think that there are different elements within the party that are looking at it very differently, maybe at least two elements within the party. And so, the smarter approach in my mind would be to allow the agenda to grow somewhat more organically when it comes to healthcare, because obviously the next nominee of their party, I mean, Jeanne probably talked about this a little bit, but the next nominee of their party is going to place a huge imprint on the policy, the forward-looking policy of where the progressive movement, where Democrats go over the next several years. So I think if you're thinking about it smartly, you want to do as little as possible until there is a nominee, because you don't want to get ahead of them, you don't want to prejudice that conversation. The slightly less smart thing to do would be to kind of drive as far to the left as possible early to placate an electoral base that's feeling increasingly good each day that passes, given that seats seem to keep flipping from Republicans to Democrats and wake up every morning. So, I mean, it'll be interesting to see which dynamic prevails, but without a question, there is this, I think it's really an existential question of what they do next. Your original question about the likelihood for some kind of bipartisanship around some of these technical questions, I still think that's a relatively low likelihood outcome, just because there's no incentive for bipartisanship in this Congress coming. There's just really, that's not where the energy is. And so I don't see them being able to compromise, particularly as they have to address some other non-healthcare issues which are more controversial and will drive further a wedge between the two parties.
I'm happy to say I really agree with Rodney on this question. I do think that there's some eagerness on the part of the administration to have a legislative win on drug pricing. It's something that the president has, in some cases, had to be actually held back on. And now, with a different makeup in the U.S. Congress, I think. I think it's quite likely that we would see something come together, and what shape that might take, I'm not sure. But just about every speech Secretary Azar gives, this comes up, and I think, given the history of the rhetoric from the administration, we're likely to see something on drug pricing specifically.
Okay. Yeah.
Susan?
Yep.
Marcia Gold. Just a question. I've been listening, and this in some ways stems from some of the same perspective I think the last question had. We started out saying positioning for 2020, and the papers were great. I thought they were really interesting, and they showed things. But what I seemed to sense is there was no overlap of those circles. The Democratic discussion is over here, the Republican discussion is over here, and there's not even agreement within each of those circles. So each group is discussing it, and what does that mean for the relevance of any action coming out of this? I think, Rodney, you said in the beginning, there was often some dynamic where there was some middle ground that some Republicans would support the Democrats or vice versa. And so I'm trying to figure out what this means for actually progress on these issues, if you can't even agree on what the question is.
I'm not.
Yeah, I think that's just a statement. Let's just go on. I don't think.
I think, Marcia, that basically that topic was addressed in the last question, but it's very close to what I was going to ask about.
I think the two areas to look are waivers and regulations. That's where you're going to see the action in the foreseeable future.
So we're going to go to Sarah and then the gentleman here.
Hi, this has been such a great discussion. Sarah Collins from the Commonwealth Fund, and I just want to build off of Varsh's comment and just listening to this discussion. And I just wonder, the Commonwealth Fund has a state scorecard that we've been running that has 40 different indicators of healthcare access, quality, cost. We've been running for several years now, so we've got a huge database of how variables differ across the states. So we kind of know how the Affordable Care Act played out across the country. There are wide variations still. Despite a federal floor, states have had the ability to innovate and do different things. So what I'm wondering is whether on the state innovation issue, if there is overlap. So is there a way of looking at how states are currently performing? We've got a huge evidence base. And whether we kind of know how they might respond to block grants or they might respond to more flexibility. So is that an area, just in a practical, setting aside the ideology of federalism and whether we believe more in public and state level innovation, is there a place there that you might, that the parties might be able to come together in a practical sense, looking at what might be solved better at the state level versus what seems to need more of a federal role?
Yeah, I mean, and I think Josh alluded to this. Governors and state legislators have to deal with practical realities in a way that Washington folks don't, all right? And so I think, to your point, there is a lot that's happening at the state level. Whether the question is if there are things that could be replicated, things that are working well that could be replicated, that might go into, for example, some kind of model guidance, I think that could be very useful. But it speaks to a broader question, which I didn't get a chance to touch on, which is, how this approach responds to states that might want to take things in a very different direction. So let's say, for example, if you posit that state innovation is a good thing, then you must also then be equally okay with the state taking that freedom and doing something that no conservative would ever want to do. And in my view, the answer to that has to be, well, yeah, obviously, right? The nature of innovation is that you can have people going in vastly different directions, and you see kind of what works and what doesn't. And so I am, and there is disagreement amongst conservatives about this, so I don't want to represent this as something that everyone agrees on, but I take the view certainly that, look, if you want to use this as an opportunity to see whether your pet idea works, even if that idea doesn't comport with what I think is good policy, then part of the risk you run, I guess, is that that's going to happen. And politically, maybe that is enough of a kill shot, because you'll have conservatives saying, well, I don't want to sign up for that. I'm not willing to really be a federalist if it means that people are going to do things I don't like, to which I would say, then you're not really a federalist.
Can we get a microphone up here in the front? Great, thank you.
Lou Gagliano, Coalition to Transform Advanced Care. We have one model that is a good example, diving down even below the state level, and it came out of MACRA. A number of programs in MACRA created penalties for which it drove a new concentration on quality delivery, particularly in hospitals. I'm thinking of the readmission issue, which fundamentally changed how hospitals operated, as well as things like infection rates. And so the whole value-based situation that grew out of that, I do think, has changed the way care is delivered. So I'm using that as an example of how a local best practices kinds of trends can help. Comments?
Yeah, and I would, Sonia, and I would say, to this conversation about where is that common ground, in some ways, when you look at avenues for, improving quality, having smarter spending, et cetera, a lot of those ideas are common. There are differences, but there is a lot of commonality across both sides of the aisle. And I think one of the questions then is just, what is the chassis upon which that is done? And I think that there's disagreement on the chassis, but I think when it comes to improving information and aligning incentives, I think that there's a lot of common ground there.
Right here.
Hi, Cornelia Hall from the Kaiser Family Foundation. Thanks for all of your comments. My question picks up on Sarah's question and a few other threads, including Adaeze, you mentioned evidence, data, state innovation, and Arkansas. And I just wanted to ask about the importance of evaluation in these state innovations. Arkansas's implementation began, the evaluation still hasn't started, people have lost coverage, and we don't have any information about who they are, why they lost that coverage, that sort of thing. So if we're going to, incentivize and promote state innovation, what are the other pieces of that to know how these things are working? Thanks.
Yeah, thanks for that.
Sorry, go ahead.
Okay, I'll start.
Go ahead.
Please, yeah. So thanks for that question. When we were in the administration, even when we were doing MACRA, the first set of rules for MACRA, every single demonstration that we were putting out through CMMI, the first thing that we looked at once the demonstration has been designed is the evaluation component, literally building that in, not to the level of specificity we would then expect the contractor to come in with, but making sure we understand what are we looking for, how are we going to define success, and how will we define failure. I have been looking for that, I'll admit, in the last couple of years, and it's been very hard to find. It's hard to find that in simple things like funding for the variety of opioids interventions we see, right around the $3 billion, just as an example. Once you don't have that, then you can pretty much expect anything to happen. So it's hard for me to imagine as a policymaker that the definition of success for any policy is that 8,000 plus 3, so let's just say 12,000 at this point, get kicked off of a Medicaid program in one state in a space of about 6 months. Now, if it turns out that somehow all these people are fraudulently enrolled in Medicaid, fine. But the fact that that question isn't teed up and that outcome is what it is right now, without any evidence to support that outcome, to me is quite troubling. And that's why I think in the next year, we will start to see a little bit more oversight, a few more questions, to really get at how these policies are being implemented across states. So I do think that that's such a critical point that we often lose. And if it's not part of the discussion a priori, we get to see what we're seeing in Arkansas and potentially other places.
So I would just say, anybody who talks about innovation and federalism should be talking about putting into place a robust, standardized evaluation infrastructure on which we are going to act. Not only that we're going to do the evaluation, but then when we find out that something worked or didn't work, there will be consequences for it. We are nowhere near there.
Gentleman up here, and then we'll come back to the center.
Carl Polzer. I work on health policy, long-term care policy, and helping low-wage workers with financial security. Before I ask my question, on the drug pricing, I think the main function of that is it's a positive thing, but it's just the Republicans will collect a lot of money from interest from pharma to try to water it down. So it'll help them arm for the next election. Whatever happens will be preliminary. So I'm trying to think of one small thing in this political environment that could help low-wage folks with their health care, and that would be to go to the Healthy Families Act, which is stuck behind the Family Leave Act, giving people, making sure they have a few sick days. You have 35 million people out there that they either risk losing their job, and they go to work sick, and a lot of them are areas that I work on, like long-term care workers, daycare workers, food preparation workers. And so the states 10 states have done something about it, and the federal government it would cost nothing, except maybe tiny subsidy for the transition. Employers should be doing it anyhow. And it makes sense if you're going to require people to work to get on Medicaid, they need to take a day off of work to use their benefits without risking losing their job. So that's just my comment.
Okay. Let's go right behind Carl, and then we'll come to the aisle here.
Hi, I'm Erin Brantley, and I'm at George Washington University. And my question is for Sherry. Do you see any possibility, or did you think about the possibility for Democrats to add in additional protections in Medicaid around work requirements, premiums from the legislative side, so that, you know, going forward into 2020, there's a possibility of strengthening protections for people no matter what state they live in?
So we didn't talk about that in our paper, but that is certainly something, I mean, the debate around Medicaid work requirements is certainly something that is invigorating a lot of people. I think I'll just leave it at that.
I'm Dr. Caroline Poplin. I'm a primary care physician and a health attorney. It seems to me there's a gorilla in the room, and the gorilla is cost or price. Alan started out by saying that people are very upset about the high deductibles or the premiums or the inability to pay for health care or health insurance. And Sherry mentioned price controls, and Rodney said that's what Medicare for All is. And my question is, the Affordable Care Act was supposed to fix prices and costs by market forces and competition, and that just hasn't happened. And I think there are reasons why it probably never will happen. And we should go to price controls, and we have some of them already, the RBRVS system and the DRGs, and that could be extended. It sounds terrible to American ears, but that's what every other developed country does, except Switzerland, which is a special case, and the Netherlands, where it hasn't worked so well.
So is that central to the platform of either party?
So I think there was a lot of discussion about what to do with administered prices, where to use them, how to move where that's appropriate. That's definitely one of the things that we take up in the paper. It is also a challenging thing to do, and I don't think it's not I think moving to Medicare prices across the entire U.S. healthcare system tomorrow is not going to happen. So we need to be thinking about where we need to be using administered prices, and I think there are a lot of options, including some of the out-of-network discussion that's happening right now, which might have interest.
So I'm gonna take one quick question, and then I'm gonna wrap it up. So go ahead.
Hi, I'm Caroline Steinberg. There are a lot of other things that are swirling around that are going to influence what happens over the next 2 years that we haven't really discussed, and I'd like to get some comments on those. For one, are what's going on in the courts. I mean, there is a major ACA case going on, and then there's a whole host, I think something like 18 other cases on the ACA and Medicare, Medicaid work requirements, et cetera, et cetera. And then there are also the efforts of Trump to kind of kill this by 1,000 cuts. And in particular, this new idea that states might be allowed to use subsidies for non-compliant plans. I mean, I think the one thing that has stabilized the market is that 85% of the people are getting subsidies, and if you expand that to non-compliant plans, that could really cause things, I think, to crater. And I don't know if that could play out over the next 2 years. And then the other thing that
why don't we stop there?
Okay.
Reactions.
I think those are all things that Congress is going to be talking about and thinking about. I don't think that they will be particularly the centerpiece of a presidential campaign, but you're right. All these things are up in the air, and something's going to have to be done.
Texas versus Azar, Texas wins, plays up, and the timetable is summer of 2020 at the Supreme Court. That could get interesting.
Yeah, I mean, I think that given that we're in a period of relative stability right now in terms of premium as we look at 2019, I've always thought 2020 was going to be the bigger question. And some of the dynamics you're talking about at the state level will really play out into 2020, particularly the question of how the short-term limited duration plan rule might impact the health of some of those markets. And if anything forces congressional action at the end of 2019, it will be because of the rate filings and escalation we see in the summer and fall of 2019.
And if the administration came in and said, we're done with silver loading.
Right.
Okay, this has been a terrific conversation. I'm going to close with a small observation, which is that we, as was noted at the outset, at the moment, you don't expect a big primary fight on the Republican side, but you can expect a big primary fight on the Democratic side. And I'm going to bring this all back to this notion of the policies that are presented and how those policies are presented depends very much on what problem you're trying to solve. And historically, we know that core Republican and core Democratic voters view the problem to be solved quite differently. The center is more in play. And so the potential of a primary fight in the Democratic side focusing more on what Democratic primary voters care about, shifting the candidates more to the left, and then having to swing themselves back to position themselves more to the center for the general as they're facing a different electorate that views the problem differently, I think is another dynamic that's going to play out here. I am struck by the comment and the reactions. It's hard to find middle ground here. We are somewhat operating in separate universes. It may be that delivery system reform is the middle ground, but it's also not at all salient to the general public, so it doesn't really affect this conversation very much. So I just want to say, again, thank you to the Commonwealth Fund. Thank you to our authors, Jeanne, and the special role Jeanne played, not just as a co-author, but also in this overall endeavor. This is a substantive conversation. We highlighted some areas where we could just argue all day, but I also think we really set the stage for some very difficult substantive choices that the parties are going to have to make over the next couple of years, and that's what we set out to do. So please look at the papers. They are now available, and we'll look forward to this conversation continuing. And as I close, just please thank our presenters and our panelists.